Good evening, friends. So I'll be talking on this topic, fluid resuscitation in sepsis. Uh, so here in this talk, the main focus is whether the earlier resuscitation of 30 ml per kg, is it something that is validated, or are we overdoing by adopting the surviving sepsis guidelines, which suggest that we should give 30 ml per kg as an initial resuscitation fluid. So we have clearly understood for most of the trainings, there are multiple videos I've done on this. So where we have debunked the fact that we should over resuscitate the patients and cumulative positive fluid balance is bad. So this is something I've clearly understood. But this talk which I gave in Vizag on 30th March is mainly focusing on this early resuscitation of 30 ml per kg as suggested by surviving sepsis guidelines. Is it something that we should adopt, or this should be debunked is what we will be looking at. So let us look into the evidence of this. So what does surviving sepsis guidelines tell us? So 2021 is the guideline that came. So it does put a question on PICO. PICO is patient population. When we put a research question, it's the patient population, intervention, comparison, and outcome that we look at. So 30 ml per kg of fluid, 2021 recommendation says should be adopted within 3 hours of resuscitation in patients with septic shock to optimize the blood flow, assuming that in patients with septic shock, the blood flow or perfusion to the organs is compromised, and to circumvent that compromised perfusion, one should give 30 ml per kg. So 2021 recommendation still endorses this viewpoint, although they have weakened the strength and quality of evidence, because they do acknowledge that the strength of evidence is weak and it is changed. So from 2016, where the strength and quality of evidence was stronger, has been weakened in 2021, which means surviving sepsis guidelines do acknowledge that the strength of evidence has weakened for this 30 ml. So they do acknowledge. So it's already getting debunked. So although I'll be talking about the evidence and trying to dawn upon that 30 ml per kg is something that we should not adopt. So even the SSC guidelines do acknowledge that the evidence for this has been weakened. So the recent studies shows by adopting this strategy of giving 30 ml per kg causes more harm to the patients. And these are the studies. So the experimental studies, observational studies, and randomized controlled trials have shown that the restrictive fluid resuscitation does improve outcome. And these are all the studies that have shown. And the striking or the landmark study came from this Maitland et al. Basically, it was a study done in Ugandan children, which is a FEAT study, which you all must have heard. We showed that the liberal fluid resuscitation worsens the outcome. So that is clear. So even the SSC guidelines does suggest that initial fluid resuscitation, from the strong evidence, it has been weakened. But how about, so that is one aspect. How about liberal or restrictive fluid strategy? Again, the SSC guidelines does not do suggest that there is insufficient evidence of restrictive, because we have clearly understood that we should not maintain too much of cumulative positive fluid balance and we should restrict. But SSC guidelines does not put any recommendations on this positive or cumulative positive fluid balance. Although, so having no recommendation itself is a new sort of a suggestion that they have made from 2016. So basically, that initial resuscitation, they weakened the evidence. With regards to restrictive or liberal on a long term, with regards to cumulative positive fluid balance, SSC does not make any recommendation. So now the whole question is, where did this whole concept of 30 ml per kg of fluid resuscitation come from? So basically, there were two important studies. So this was an IMPRESS study, where in IMPRESS study, they showed that by adopting this resuscitation bundle compliance, which means adopting this early fluid resuscitation or early goal-directed therapy. So if you look at this is the largest registry data, IMPRESS study, which was published in 2015, where they showed if you adopt the early goal-directed therapy or the compliance to resuscitation bundles, so your mortality will significantly reduce, because if you adhere to 7%, if you adhere to the compliance bundles, your mortality is high. But if you adhere to the compliance bundles with increasing percentage, your mortality can be reduced. So this was an impressive study which said you adopt this early resuscitation guidelines, you can reduce the mortality. And all this came from our reverse study way back in 2001, where he showed that early goal-directed therapy with CVP more than 8 millimeter mercury or mixed venous saturation more than 70% significantly reduces the mortality. So this we all adopted way back in 2000. We did adopt this, but later on we realized this caused more harm than any benefit. That's what we are here to reason out. And this was debunked in trio-EGDT. When I said trio-EGDT trials, there were three trials that came. So Arise, Promise, and Process, which clearly showed that EGDT, giving aggressive fluid resuscitation early on, did not change the outcomes. So this, but people still argue. So even trio-EGDT clearly showed that the liberal fluid resuscitation did not change the outcome. But we started arguing because in this trio-EGDT pre-randomization, they had given this fluid bolus of at least 1 to 2 liters was given at a rate of 20 to 30 ml per kg as initial resuscitation. So people do argue that still it holds promise. So that is the sort of an argument that we need to debug. So this comes from this study, Seymour et al. So this was the biggest study, as you see, done in 26,978 patients. They looked at the patients who received 30 ml per kg study. So here we are to debunk that 30 ml per kg does not help. So in this particular study, they looked at all these patients who got 30 ml per kg at various time intervals, and they looked at hospital mortality. And if you see the confidence interval, it did not have a bearing on mortality with every hour delay, which means you either give 30 ml per kg at admission or at the end of 6 hours or later. It did not have a bearing on improving the outcome. So this is the first study which, which sort of shows signals that early resuscitation with 30 ml per kg not necessarily has improved the outcome or reduced the mortality. And this is an interesting statistics. Either you give 30 ml per kg less than 6 hours, because our surviving sepsis is telling within 3 hours you should give 30 ml per kg. This particular data, if you see, either you give less than 6 hours or you give even after 6 to 12 hours 30 ml per kg cumulatively, there was no change in their outcome. So there was no mortality reduction. If you see, confidence interval was not significant. So this was a very striking study which tells either you give 30 ml per kg within 3 hours or you do not give, or it's a delayed sort of administration. It did not have a bearing on mortality. And this is another study by Merrick et al. Where they looked at severity adjusted observational study. And here also they looked at large data of the patients, and they showed in the first day, most of the patients got less than recommendations. And in this particular study, if patients got more than 5 liters of fluid in first day, it increased the risk of death. So these are the two studies which showed harm by giving 30 ml per kg. At least this Merrick study showed harm if you give more than 5 liters, or 30 ml per kg did not show any improvement in the outcomes in these two studies. So what are the other issues with 30 ml per kg recommendation? Because one could argue 30 ml, what kg you would take, whether you would take actual body weight, whether one would take predicted body weight, or one should take ideal. So there is no clarity on what is the weight. And tell me, I can ask like who exactly does exact weight-based administration? It is always an estimate. And there is problem in extremes of weight. If patient is weighing very less, or suppose if you take a patient who is obese at 150 kgs, and if you take that weight as a literal, then the 30 ml per kg amounts to 4.5 liters of fluids in 1 hour. So that is something which possibly can cause more harm than benefit. And as I said, it is very prudent and evident and intuitive that height and weight, when we are dealing with a septic shock in an acute phase, are almost always unavailable. And most of the time, we take an estimate of the weight, and this estimate becomes unreliable. So the authors argue that one size does not fit all. So one has to individualize the fluid therapy to the patient needs rather than taking an ad hoc weight estimation and administering 30 ml per kg leads to more harm, and it should be personalized to the patient sort of a needs based on the hemodynamic monitoring is what the author trying to argue. So this is the sort of thought process that we are in at this point of time. So, so there are other issues with the 30. So this is another interesting study by Trong et al. In 2019. They looked at three subgroup of patients in 1027. CKD, the compliance to the SSC guidelines was 42.3. In heart failure, it was 40.9, and liver failure, it was 38.5, which means that initial fluid resuscitation in patients with these background problem coming with septic shock, the adherence was less than 50%. And they showed even by not adhering to that, there was no difference in the mortality. So this is similar to the Seymour study, where he showed that 30 ml kg, whether you give it within 6 hours or after 6 hours, it did not have bearing on mortality. This study endorses that viewpoint that in patients with these comorbidities, there was a compliance lesser than 50%, but it did not have any effect on the mortality. So the authors do subscribe that blindly following surviving sepsis guidelines can be more harmful than any benefit. So this is an interesting thing which I need to again talk to the audience about the way the whole fluid trials have progressed. So this is an important thing that you can all keep it as a summary one. So reverse trial, who did the earlier EGDT, early goal director in 2001, used 168 ml per kg as a cumulative resuscitation fluid. And if you take for a 60 kgs, it amounts to 10 liters of fluid resuscitation. And then came the trio-EGDT, which is the process, promise, and arise trial. In process trial, which came in 2014, they used 130 ml per kg. That also amounts to 7,800 ml for a 60 kg as a resuscitation fluid. In Arise, they use 109 ml per kg, which amounts to 6,480 ml. Promise, which came from UK, used 98. So what I want you to appreciate is how in the subsequent trials from 2001 to 2015, we are coming down on the cumulative amount of resuscitation fluid as a standard of care is what I want each one of you to appreciate. And then came the RICH trials. If you see RICH trial, which came in 2019 by US, have further brought it down to 47.1 ml per kg as a cumulative resuscitation fluid. So where we were, the reverse spoke about 10 liters as a cumulative resuscitation fluid. In 2019, we came down to close to 3 liters. From 10 liters, we have come down to 3 liters. And refresh trial, which is 2018 by Australian, came down to close to 2 liters. And the most recent classic trial, which came in 2022 by the Scandinavian group, came down to close to 1,800 ml. And the latest which came is the Clover trial, 2023. And look at the amount of cumulative resuscitation fluid they've used. It is 1,267 versus 3,400 they've compared. And all this Clover trial and classic trial both did not show any difference in mortality by using so restrictive fluid resuscitation. So, what is liberal in Clover, which is 3,400 ml, is restrictive in process, arise, and promise. This is what I want you all to appreciate. So, the cumulative resuscitation fluid from 2001, which was 10 liters, has come down to close to 1.5 liter in 2023. So, we are talking about restricting the initial. So, the whole progression of the science has been to restrict. So if we have to attain around 1.5 liter of cumulative fluid, we cannot afford to give 30 ml per kg at the outset, because if you give 30 ml to a 60 kgs, it will be 1.8 liters. So we are talking about attaining the cumulative fluid, where the whole cumulative fluid resuscitation, we're talking up to around 1.5 liter. So we cannot afford to have 30 ml per kg. It's already debunked, is what I'm wish to say. When you look at the progression of the trials and the progression of the fluids that they have been administrating, so the cumulative fluid resuscitation has been progressively been coming down. So when we talk about fluid responsiveness, gone are the days, gone is the time where we say we give 30 ml per kg to improve the perfusion. Our whole concept is we give fluid to look at the change in the cardiac output. So that is our understanding. So we need to have hemodynamic tools to ascertain, and we have clearly understood keeping patient in this dry state is dangerous, but overloading the patients is equally dangerous. And these are the studies which have clearly shown by overloading the patients, it increases the risk of mortality in all the subgroups of patients, sepsis, ARDS, intra-abdominal hypertension, AKI. So all these patient groups, the mortality was found to be higher. And large volume rapid boluses is given with an intent to restore blood volume, restore blood pressure and MAP, and improve oxygen delivery. But we need to understand the perils of overdoing this sort of a resuscitation. And role of maintenance fluid in ICU, all of us agree that it is minimal. So one needs to bear in mind the 4 Ds while you are resuscitating. So appreciate the type of fluid that you are using, the duration of fluid, the dose of the fluid, and most importantly, even after you give the bolus, keep in back of mind that one needs to de-resuscitate the patient, and that is something that we need to adopt very early on. So just to give you a historical perspective as to, it's not like now we have recognized the perils of over-resuscitation. Way back in Second World War, in Vietnam War, so for preserving our renal function test, they used to give large volume of fluid, and that is where they had these patients developing wet lungs, which they called it as Danang lungs. So, so historically also it is shown by administering large amount of fluid, so the lungs were getting affected and they did develop ARDS and so on and so forth. And the whole concept of supranormal cardiorespiratory function with goal-directed fluid therapy has been debunked. So, uh, so why is there? So, is there actually any evidence for fluid resuscitation? So, what we have understood is in sepsis. So, this is important. So, the Frank Sterling curve moves down and to the right, which means if you look in sepsis, there is some sort of a myocardial dysfunction that already sets in, and giving fluid bolus, not necessarily you will have an improvement in the cardiac output the way it happens in a normal individual. So, the Frank Sterling curve gets moved to the right and down. So the response to the fluid bolus remains suboptimal in sepsis. So when should we test fluid responsiveness? Obvious hypovolemia, one should not test for fluid responsiveness. So if there is an obvious septic shock or hypovolemic, obviously you'll give fluid, but one need not adopt the 30 ml per kg. And when there is an ongoing hemodynamic stability, even after initial resuscitation, when you have lactates going up, urine output coming down, capillary refill, which is sort of affected, and there is a mottling. So this is where one has to adopt some advanced hemodynamic sort of modules to assess fluid responsiveness. Even if these hemodynamic tools show fluid responsiveness, only half of them respond to fluid. So these are all the caveats, which means even if you do IVC, distensibility, collapsibility, pulse pressure variation, stroke volume variation, and this is in the face of patients having increasing lactate, reducing urine output, capillary refill which is delayed, and mottling. Even there, you see these hemodynamic tools telling their fluid responsiveness. You give fluid of 200 ml or 250 ml, only half of them respond by improving the cardiac output. So these are the caveats of fluid resuscitation that each of the ICU trainees should bear in back of mind. And this is a very interesting slide, which again came from Andromedia study. So this is an important slide fixed in your mind. See the response. So this is a good study where they showed your fluid responsiveness at the presentation is good. They respond 57%, only 57% respond at admission in emergency with septic shock. But after 2 hours, you see the responders, the fluid responsiveness comes down by 22%. At the end of 4 hours, your fluid responsiveness is only 11%. 6 hours, only 10%. At the end of 8 hours, they are not fluid responsive. Even if your hemodynamic tools are telling they're fluid responsive, they may not be. So that's why we have adopted the concept of de-resuscitation and mini fluid response or mini fluid aliquots or mini fluid resuscitation. So, and we have increasingly understood the cardiovascular dysfunction that is associated with fluid bolus, and that was shown in this FEAST trial. So, this is a landmark trial which was done in Ugandan children. It was done in 3,141 children where they compared 40 ml per kg of saline versus 4% albumin versus no volume resuscitation. And they found that in children who got this 40 ml per kg of saline, which is a huge bolus, like we are talking about 30 ml, there was 40% increase in the mortality. And this mortality happened because of refractory shock and cardiovascular collapse. So, which means to say, even in adults, if you overflood the patients, there is a possibility that hemodynamics can even worsen. So, your intent to correct hemodynamics by overflooding them can lead to cardiovascular collapse, is what one could decipher from this study. And this was another interesting study from Zambia. So, where they showed that in 6 hour protocol, where they gave 2 liters within 1 hour and 2 liters after 4 hours, you saw that 28 days survival was less where they got this as compared to the usual fluid resuscitation. And in fact, the vasopressor need also was higher. So the FEAST trial and this particular study, which published in JAMA, done in Zambia, showed that early resuscitation, in fact, with increased boluses of fluid worsen the hemodynamics and reduce the survival. And we have clearly understood the harm caused by fluid overload. I think there is a separate video for this. So 10% fluid accumulation leads to worse outcome. A lot of studies have been done. And there are a lot of pathophysiological sort of effects because of fluid overload. It can lead to a lot of fluid sequestration in multiple organs. There can be fluid sequestration in the brain, worsens the delirium, increase in the ICP, and there can be fluid sequestration in the myocardium leading to dysfunction, and there can be increase in the CVP. In the lung, there can be fluid sequestration leading to hypoxemia, hypercapnia, and reduced compliance and pleural effusion. And there can be fluid sequestration in the liver, causing hepatic compartment syndrome. And there can be fluid sequestration in the lung, leading to increased interstitial pressure, reduction in the glomerular filtration rate, and renal compartment. So, what basically this pictorial diagram shows is if you overflood the patient with a lot of fluids, the fluid gets sequestrated in all the uh, tissues and all the organs, leading to compartment syndrome. There can be hepatic compartment, there can be renal compartment, there can be a lot of fluid sequestration within the intestine as well, leading to worsening of the abdominal compartment syndrome, and there can be compromise in the abdominal perfusion pressure also. So this is sort of keep in mind that more cumulative fluid balance, they all get sequestrated within the organs, leading to organ dysfunction, is what we have understood. And if you have to correlate to the clinical evidence available, this is the biggest sort of a meta-analysis with 11 randomized controlled trials where they have looked at conservative versus liberal fluid, and they have shown that conservative patient group where deresuscitation was done, ventilatory free days was increased, which is good, and ICU length of stay was decreased. And they concluded that in patients with sepsis and ARDS, conservative or deresuscitation versus liberal leads to better outcomes by increasing ventilator free days and reducing the ICU length of stay. And these are the other data, subgroup analysis they've done from the WASH data, where they showed in patients with septic shock, positive fluid balance at 4 days increases the mortality. And for optimal survival, positive fluid balance should be less than 3 liters in 12 hours. And this was the data from SOAP study, where again they showed positive fluid balance increases 60-day mortality, and early initiation of RRT led to better outcomes. So all this subgroup analysis shows that excess fluid on board within the body at the end of certain time after initial resuscitation is bad for their outcome. So that's the last concept I want to highlight. There's something called endothelial glycocalyx and fluid therapy. So we give isotonic fluid, hypotonic and hypertonic. When we give saline as a fluid bolus, it leads to hyperchloremia because the chloride content is 153. It leads to something called hyperchloremic metabolic acidosis. We have understood this, giving more saline as the initial fluid. And this hyperchloremic metabolic acidosis is known to cause damage to the endothelial glycocalyx. And endothelial glycocalyx also get disrupted or damaged due to shredding that happens with a rapid fluid bolus at a with a high quantity, and this can lead to acute kidney injury, and it can lead to coagulation dysfunction, and it can lead to loss of vascular endothelial integrity, leading to DIC and so on and so forth. And this was highlighted in the SMART and SALTED study, where there is a focus on using balanced solution to lessen the AKI and to keep the chloride at a lesser level. So the take-home message at the end of all this, so as you say, I've bombarded with a lot of studies, basically to dawn upon us and to have a good conviction that more fluid is bad. But here the whole focus was on early fluid resuscitation, even with a large bolus, can lead to harm, was what I wanted to drive in this talk. So aggressive early fluid resuscitation has no scientific evidence, and we have increasingly recognized early aggressive fluid resuscitation can cause harmful effects with regards to cardiac toxicity, vasodilation, and we have seen that from the FEAST study and from the Zambian study that it can lead to hemodynamic compromise. And we've increasingly recognized that glycocalyx, which is a sort of a slimy layer on the endothelial cells in the vessels, get disrupted, and this can lead to organ dysfunction like AKI, acute kidney injury, and coagulation dysfunction, and it can lead to cardiovascular collapse. So, in your zeal to optimize hemodynamic status, you give more early fluid resuscitation. In fact, that can lead to hemodynamic compromise because of the direct cardiac dysfunction vasodilatation and cardiac toxicity that can happen, which was shown in the Peace study and another study that came from Zambia. And the increased fluid sequestration cumulatively over 72 hours or over 5 to 7 days can lead to multi-organ. And we have recognized this because all this excess fluid gets sequestrated in various organs. In the brain, it can increase ICP. In the kidney, it can cause renal compartment syndrome. In the liver, it can cause hepatic compartment. In abdomen, it can lead to abdominal compartment. And because abdominal compartment, we know, can cause other organ dysfunction. So the summary, the take-home message for all our trainees is whatever initial fluid resuscitation you are giving should be individualized to the patient needs, should be personalized to the patient needs, and this should be guided by your hemodynamic parameters, and one should be restrictive with regards to the amount of fluid you would give to improve outcomes. So this would be your take-home message. So thank you one and all. They can visit my website www.drpradeep.com to read here. So thank you one and all.